Hello, I'm Associate Professor Bruce Walker from Murdoch University. This is a re-recording of a speech that I gave to the COCA and Chiropractic Australia National Conference in October 2015 in Melbourne, Australia. It's entitled The New Chiropractic. Manual therapies, including manipulation, have been used for centuries, indeed even thousands of years. Many cultures have had practitioners that administer these manual therapies for musculoskeletal pain, and historically they can be classed as traditional healers, including bone setters in England, kung fu masters in Asia, but more latterly osteopaths, chiropractors and physiotherapists in the Western world. Traditionally, these manipulations were taught father to son, mother to daughter, or master to apprentice, and in some cultures this still occurs. Although this speech concentrates on chiropractic, much of what is discussed has implications for other manual therapy professions. Chiropractic is 120 years old, and in that time has progressed from a full alternative medicine concept to be part of complementary medicine, and in some jurisdictions has primary care status. Some argue that historically chiropractic has elements that are consistent with religion. Regardless, what can be said is that the profession's history, conduct and overall contribution is checkered by good and by bad. The good can be summed up by recognising over a century of improvement to public health by improving pain and disability in countries where chiropractic is practiced. It can be asserted that this has provided significant economic savings and improved productivity for those individuals in their respective countries. There has been important global benefit from chiropractic treatment, and although this has not been estimated, it must be enormous. The profession can hold its head up high when reflecting on this positive population benefit over time. Before moving on to the bad aspects practiced by a minority within chiropractic, I contend that the global good produced by the profession far outweighs the bad, and this point should not be ignored or overlooked when considering the speech. So to the bad side. The bad side of the profession has been the subject of much controversy, publicity, and even indeed previous F.G. Roberts addresses at COCA conferences. The following practices represent some of these bad practices utilised by a minority that continue to cause significant reputational damage to the profession. These include adherence to a flawed chiropractic ideology centering on innate intelligence and vitalism, claims of cures for visceral and other non-musculoskeletal conditions, anti-vaccination propaganda, anti-drug and anti-medicine propaganda, anti-physiotherapy sentiments, misleading and deceptive advertising, open plan clinics where multiple people are treated in the same room fully dressed, unscrupulous contracts of care, over-servicing, obligatory full spine x-rays, the use of the term subluxation as a valid diagnosis, unnecessary treatment of babies with pristine spines, biologically implausible diagnostic tests and therapies, unfounded claims of decreased immunity from subluxation and increased immunity from chiropractic treatment, lifetime chiropractic care in the name of wellness, and an unhealthy disregard of clinical research, evidence-based practice, natural history, and the placebo effect. So, where is the profession at this moment in time? Currently, there are many countries that have registration and licensing for chiropractors, educational programs with somewhat differing standards and emphases, housed mostly in private colleges, but with a minority in state-funded university programs. There is some limited private health funding for patient consultations, minimal public funding, very little hospital access, and research that can only be described as embryonic. The profession by and large graduates competent manual therapists who contribute well to their communities and are good professional citizens. But there are still aberrant elements with a profound retrograde ideology. These individual and organised elements have caused the profession untold reputational damage and continue to do so. As a consequence, our profession's reputation is commonly poor among other health professions with whom we are compared, and our approval is variable within the community at large. So, with all this in mind, how do we progress our profession to make it equal and worthy partners in the health arena? A profession where we command a healthy respect by others in the health sector, policymakers and patients alike. A profession where we are welcomed as legitimate partners in allied healthcare delivery. To achieve this, we have a stark choice. We can maintain the status quo, keep on the current track, and forever be regarded as alternative or complementary practitioners who are just a bit different. Or we can develop a vision for a new chiropractor who has the recognised attributes of a fully worthy and functioning allied health professional and contributes more in their respective health field than others do. The content of this speech aims at achieving this goal. To advance the profession globally over the next generation and to achieve the vision just set out, a 10-point plan is proposed. It is recognised that even if this plan is adopted, it will take a significant generational time to succeed. Hopefully, young members of the profession are sufficiently motivated to take on this cause and see it through. If they do, the reputation of the profession will be enhanced to the extent that chiropractors and chiropractic will be seen as legitimate partners in the healthcare delivery system. It is reasonable to speculate that this goal matches the aspirations of our younger professionals as they look forward to a long and virtuous career. So to the plan. Point 1. There is a need to improve pre-professional education for chiropractors. Should we be in universities or private colleges? Chiropractic education should, where possible, be conducted at universities. And this does not mean small single-purpose institutions that are deemed universities in name only. Why is this recommended? Primarily because state universities insist on intellectual rigour in their learning and in their research. And they require staff to be research active. Chiropractic courses need to have an underpinning pedagogy that insists that content is taught in the context of the evidence that underpins it, and that students obtain the necessary training to question and critically appraise as part of their lifelong learning. Private colleges and programs, such as we see in the USA and other countries, do not usually require all staff to produce high-quality research, nor can they typically grant higher degrees by way of research, such as PhDs. It can be argued that this phenomenon is partially the reason for the poor research output legacy from the USA that has left the profession in a weak state regarding the body of knowledge that underpins what it does and does not do. It is worth reflecting on the increase in knowledge the profession would now enjoy if chiropractic academic staff worldwide were research active. We also have accreditation problems. Underpinning chiropractic education is program accreditation, and this is in need of review. The question needing to be posed is, if colleges espouse to graduate subluxation-based chiropractors, how can they legitimately achieve accreditation? I postulate that it is self-evident that there must be something wrong with an accreditation system that allows this to happen, regardless of how worthy the institution is in other ways. So what about hospital training? Chiropractic education should also involve specifically relevant hospital rounds, so that students can observe patients that are truly unwell and observe the signs and symptoms they are taught in their theory classes. Hospital rounds would also allow chiropractic students to interact with other health providers and increase the likelihood of legitimate partnership and respect between health professions. But who should teach chiropractic students? The faculty of teachers of chiropractic students needs to be multidisciplinary, with medical doctors, physiotherapists and other allied health personnel also involved in their education. Simply put, teachers of chiropractic students should be the most skilled and experienced in the content area involved. Point number 2 of the plan. There is a need to establish a progressive identity for the profession. Chiropractors need to become solely musculoskeletal practitioners with a special emphasis on spinal pain. If the profession becomes the world's experts in this area, it will command the respect deserved. Importantly, it will not be seen as a collective of alternative medicine practitioners with a strange belief system. The spine care model is a means of developing chiropractic cultural authority and relevancy. The benefits that will accrue from this decision alone are potentially immense, including helping to integrate chiropractic care into the mainstream health system while still retaining self-identity for the profession. It is important that our identity as spinal pain experts be driven by current and future evidence. It is this evidence that will help shape our future identity and not ideology or dogma. Point 3. The profession should develop a generalised special interest. In the 1980s, a research arm of the psychology profession in the United States developed a special interest in health statistics. This interest made them a preeminent group in a field which stood them apart from other health professions. Their work contributed to the health statistics field generally and assisted psychology to become worthy allied health partners. Chiropractic as a profession should also develop a special interest in the health sciences that can make a worldwide contribution to other related health sciences. This could be either research-based or clinically based, or indeed both. Some possibilities are the further development and refinement of evidence-based practice, improved posture through motor control, musculoskeletal care for the aged and elderly, improving bone density, or the very important area of translating research into practice via implementation science. Whatever chosen, we need to develop a special interest that sets us apart as experts in a distinctive area. Point 4. Marginalisation of the nonsensical elements within the profession. As professionals, chiropractors should not tolerate colleagues or leadership in the profession who demonstrate aberrant ideas. If colleagues transgress the boundaries of professionalism, they should be reported to authorities. And this should be followed up with action by those authorities. It is important to reject the notion of embracing the margins of diversity within the profession. If an idea is nonsensical, express your opinion that it is and make a stand. Otherwise, your silence will be regarded as consent. Insist that professional chiropractic organisations take a public stand against biologically implausible notions and theories, illogical ideas, dangerous practices, and be prepared to report even likeable but misguided individuals. It is not treason to seriously question abnormal and implausible ideas within the chiropractic profession. In the short term, the consequences may be cathartic, but they will ultimately lead to positive change. Point 5. The profession and individual practitioners should be pro-public health. It is important to speak up openly in favour of evidence-based public health measures and to join public health associations and agencies. Chiropractic can and should get involved in health promotion and disease prevention, especially in two main areas. First, where there is a synergy with musculoskeletal disorders such as osteoporosis, falls prevention, ergonomic design of furniture and workstations, just to name a few. And secondly, to actively counter the disinformation perpetrated by rogue elements within the profession. For example, chiropractors promoting anti-vaccination views need to be countered, and also those in the profession who seek to medicalise infancy by diagnosing infants with notional spinal manipulable lesions. In this way, we will nullify the destructive reputational damage caused by anti-public health advocates in our profession and in turn bolster public health and indeed chiropractic's reputation through advocacy in these areas. Point 6. We need to support the legitimate organised profession. Practitioners should support and get involved in chiropractic organisations that are clearly ethical and evidence-based and add value to them. It is important not to expect others to do this for you. Be wary of organisations that just pay lip service to ethical evidence-based practice. Ultimately, these groups will be judged by their deeds and not their words. As a way forward, we should seek contrition and apologies from organisations that have damaged the reputation of the profession over decades. Indeed, unambiguous statements from chiropractic organisations supporting science and evidence in practice are overdue. While it is important to support progressive professional organisations, it is also worth demanding service and accountability from them. As an example, chiropractic organisations should be encouraged to market and advertise the profession at large in a non-controversial way with professional advertisements that reflect the truth and have at their heart the public good. Regular, collective professional advertising of the benefits of chiropractic for back pain, for example, is a worthy undertaking, but the advertisements must be evidence-based. Point 7. The profession should strive to improve clinical practice. Chiropractors contribute to the public health by the aggregated benefit of positive outcomes from their clinical practice. In this domain, the profession should examine all aspects of what it does and why it's done. Currently, heterogeneity in chiropractic practice is common, but it will not always be that way. In the future, more and more evidence will inform our history taking, examination procedures, selection of diagnostic tests, the therapies chosen, and the advice given. It is very likely that the future chiropractor will be more efficient, safer, and more effective in clinical practice for those with spinal pain than those of today. The profession should not be afraid of change demanded by new evidence, and indeed should be prepared to alter how we as individual practitioners communicate with patients, the diagnostic tests used or ordered, the prevention strategies recommended, and the therapies administered, including the use of medication and other interventions that are synergistic with musculoskeletal disorders. With respect to medication, there has been a significant shift in attitudes within the profession regarding the use of medication in chiropractic practice. Notwithstanding restrictive laws in various jurisdictions regarding medication, what will matter in the future is cost effectiveness and not an anti-drug dogma. Where restrictive practice laws relating to chiropractors prescribing medication exist, we should seek to overturn them. A concluding point on clinical practice is that chiropractors should, where possible, seek to work in multidisciplinary environments, as this will mitigate the intellectual isolation suffered by a proportion within the profession. Point 8. The profession should embrace evidence-based practice. Evidence-based practice is the amalgam of best scientific evidence plus clinical expertise plus patient values and circumstances. So what could be missing from this equation? It is clear that in the opinion of a sizable minority within the profession, the elements that are missing are practitioner ideology and practitioner values and circumstances. These additional self-serving and dangerous notions should not be entertained. The adoption of evidence-based practice is critical to the future of chiropractic, and yet there is resistance by elements within the profession. Soft resistance occurs with attempts to change the name of evidence-based practice to evidence-informed practice. It's worth noting that currently there are over 13,000 articles listed in PubMed on evidence-based practice, but less than 100 listed on evidence-informed practice. So why are some of our professions so keen to use this alternate and weaker term? Hard resistance against evidence-based practice occurs where it is stated that the best evidence is that which is based on practice experience and not research. This apparently is known as practice-based evidence, and it has a band of followers. It is worth illustrating the difference between evidence-based practice and practice-based evidence with an example from the literature. Table 2 that you can see is taken from the Olofsdottir al. randomised trial looking at chiropractic treatment for infantile colic. The current evidence about infantile colic and chiropractic is conflicting, but this study is useful for demonstration purposes. The left column of the table shows a decrease in hours of baby crying after chiropractic treatment and could be said to represent practice-based evidence. It is the experience practitioners often have when treating patients, or in this case, the view of parents who report improvement in the clinical setting. However, a review of the table's right column shows a similar decrease in hours of crying for babies who did not receive any treatment. Importantly, in this trial, the parents were not aware of which treatment arm the babies were randomised to. So when the right and left columns are combined, we have the first part of the evidence-based practice equation, which is defined as best scientific information. The practice-based evidence mantra appears to be, "it works." But it begs the more contemporary question, by how much and compared to what? Finally, chiropractors in the field need to become avid consumers of the evidence provided by good quality research, as this will assist lifelong learning and best practice. Point 9. The profession must support research. Research needs to become the #1 aspiration of the profession. Research informs both practice and teaching. Without research, the profession will not progress. Sadly, the research contribution by the chiropractic profession can only be described as seed-like. The slide you see at the moment is a comparison of articles published in the past 45 years by decade using the keywords physiotherapy or physical therapy versus chiropractic, and the source is PubMed. The y-axis is the number of articles published and the x-axis is the decade. The red represents physiotherapy articles, the blue chiropractic. The difference is stark and needs urgent change. The priorities for chiropractic research needs to be examined formally, but could revolve around improving clinical practice and patient benefit. This may involve themes such as the accuracy and utility of diagnostic tests, the subgrouping of people with back and neck pain, prognostic markers, prevention strategies, improving the clinical encounter, the testing of various forms of therapy for safety and effectiveness, and importantly, dose response to treatment. This list is not meant to be exhaustive, and what is important is that the profession recognises that research is its future lifeblood, and that it be encouraged and resourced immediately and sustainably. The training of chiropractors as career researchers needs to be prioritised as well. All chiropractic staff at universities and colleges need to be research active and to have or obtain PhDs. While useful research outputs are evident from many chiropractic colleges, it is not enough to have undersized and under-resourced research departments within chiropractic programs. It is worth stressing that research is a vital strategy in the advancement of the chiropractic profession and the public it serves. If the profession at large ignores research, whether in its conduct, administration, or its results, the profession will wither on the vine. It is acknowledged that the vast majority of practitioners will not undertake research, but it is incumbent on all of us to contribute to the research effort with involvement when approached and by regularly contributing funds. If this occurs, our involvement and contribution will reward the profession and the public we serve exponentially. Point 10. Individual chiropractors need to show personal leadership to effect change. Change within the profession will likely occur if individual chiropractors show personal leadership. This necessarily involves providing personal time, developing an individual and/or a collective plan, goal setting for the plan, identifying the obstacles to achieving those goals, taking action to overcome the obstacles, being accountable and providing a concerted long-term effort to effect change. As part of this personal leadership, it will be critical to speak out within the profession. Speak out and become a mentor to less experienced colleagues. Speak out and embrace those around you with similar ideals and join them in actively progressing the profession. Do not be diverted for any reason from the worthy goals of the public good, genuinely caring for patients and advancing the profession through your actions and deeds. Your personal leadership is critically important to the profession. Colleagues, with the adoption of this 10-point plan, we have an opportunity to turn things around within a generation. Importantly, we have an obligation to the public and to successive generations of chiropractors ahead of us. By embracing this plan, we can set the profession on a new path, a new beginning, and a new direction. This plan should be known as the new chiropractic. I commend it to you.